Hi there, I'm Ryan. Thank you for watching my video. Within this video, we are going to be looking at assessing the trauma patient. In this instance, the primary trauma assessment is conducted once we've confirmed the patient is not in cardiac arrest. We then move methodically through the preventable immediate life threats. These include exsanguination, airway occlusion, ineffective ventilation, tension pneumothorax, and internal bleeding from pelvic fracture. The nature of the case, the available resources with you, and exposing the patient will help guide the order of primary assessment and immediate management. We can see in my primary trauma assessment, I begin with a blood sweep. Within Australia, it is less likely that paramedics are responding to the penetrating trauma patient. While it will be case dependent, following an airway breathing circulation approach will be appropriate more often than not. Exposing the patient is a fundamental part of the primary assessment. Exposing the patient is of significant benefit for multiple reasons. It can help dictate order of immediate management. Injuries can be missed if clothing is not removed, and some of these injuries can be life-threatening. Some immediate life-saving interventions need to be done without clothing on or other items between it and the patient. Removing clothing that is covered in blood also helps prevent the patient slipping further into coagulopathy by removing wet and cold clothing exposed to the elements. Patient decency needs to be considered, but immediate life threats need to be seen and managed. If there is significant blood seen on the clothing, a thorough blood sweep should be conducted, and if massive external hemorrhage is found, it should be immediately managed before moving on to another area or along the primary survey. While it is more likely for paramedics in Australia to respond to blunt trauma injuries, penetrating trauma can still occur from classic blunt trauma incidents, and overlooking a blood sweep can result in the patient exsanguinating before reaching the hospital. Equipment that might be used at this point include hemostatic gauze with pressor bandages and arterial tourniquets. Conducting an airway check when the patient has been involved in trauma can be more difficult while trying to maintain a neutral cervical spine. A jaw thrust and mouth opening motion should remove anatomical obstruction and allow sufficient visibility to see foreign bodies or secretions in the airway. Managing the airway in an unwell polytrauma patient is difficult. Fundamental airway maneuvers and adjuncts should be used to open the airway sufficiently and allow ventilation. Multiple failed attempts for an oroendotracheal intubation can result in increased patient morbidity and mortality. Adjuncts to consider are oropharyngeal airway, nasopharyngeal airway, laryngeal mask airway, and in some circumstances, if appropriately trained, a surgical airway should be considered early in the difficult airway algorithm. At this stage, we are looking for problems with the patient's ability to ventilate. Paramedics should look for signs of chest trauma, be it penetrating or blunt trauma, to determine if there is any impedance to the patient's rise and fall of the chest. Unequal rise and fall of the chest with the altered conscious trauma patient should mean the paramedic is considering a tension pneumothorax that requires decompression. Needle decompression is typically completed with a specific decompression needle in the second intercostal space in the midclavicular line. Consideration should be made for the fifth intercostal space in the anterior axillar region if the patient has a large chest wall. Pelvic assessment could fall under hemorrhage check and be assessed when conducting blood sweeps. If paramedics feel an unstable pelvis when applying gentle pressure, they should apply a pelvic binder. Patients who have experienced blunt polysystem trauma and have altered vital signs should have a pelvic binder applied. Secondary assessment or thorough head-to-toe physical examination can be completed after a primary assessment, or if the patient does not have any immediate life threat, can be completed on its own for a thorough assessment and aid in determining likely clinical progression. Starting at the head, we are looking and feeling for signs of traumatic brain injury or damage to the skull that could impede important functions. You can see I'm feeling around the head for deformity and pressing on bony facial structures to feel for fractures that could affect the eyes or impact the airway. If the maxilla or mandible are affected, it may lead to a difficult airway if advanced airway management is being considered. We are to look in the nose and ears for CSF that would indicate meningeal damage. This is important to pass on to the receiving hospital. And a pupil check and reaction to light will aid in determining traumatic brain injury. At the neck, we look for abnormalities that could impede the airway and advanced airway management. We feel down the spinous process of the cervical spine to feel for abnormalities to indicate a spinal injury. When we're at the chest, we are looking for obvious abnormalities to the chest wall. This could be penetrating trauma, bruising, flail segment, or other unequal chest wall movements. We can then feel either side of the chest for deformities or a patient response to pain. Rib fractures will be tender. Subcutaneous emphysema will feel like bubble wrap as you press along the skin. And if you're in a quiet enough environment, auscultation of the chest can aid in unequal breath sounds that could indicate a pneumothorax. We begin the abdomen assessment by looking at the abdomen and ensure you look around as much of the abdomen as you can without moving a patient in spinal precautions. If there is internal bleeding, bruising may be seen in the flanks. When palpating the abdomen, concern should be for the patient who has a rigid abdomen and is tender to palpate. Pelvis assessment is an important part of the physical assessment. If there is a fracture to the pelvis, there is a significant risk of internal bleeding. There is a large amount of vasculature within the pelvis, and forces large enough to cause a pelvic fracture are sufficient to impact some of the vasculature within the pelvis. Each patient will be different, but all patients with a sufficient pelvic bleed can have multiple liters of blood in the pelvic space before it will self-tamponade. That is why pelvic binders are of high importance. While they may not be able to stop a large pelvic arterial bleed, they can be assisting in tamponading a venous bleed and assist in preventing clot disruption from pelvic movement. Pelvic binders are notorious for incorrect placement, and if placed too high can cause more damage to an unstable fracture and therefore increase internal hemorrhage. The key landmark for correctly applying the binder are the greater trochanters of the femur. Arm and leg assessments begin with a visual inspection to see if there are any differences between limbs. A leg that is shorter than the other post-traumatic force will likely have a long bone fracture. A shorter and rotated leg will give different information to the clinician, and they would have not even conducted a palpation check yet. We can see on the video I am using landmarks of knee and ankles to aid in determining if both legs are of equal length. Feeling for tenderness or crepitus will aid in diagnosing likely long bone fractures. Concern should be noted for deformities in the femur and humerus due to these long bones having larger vasculature and a risk for hemorrhage within these long bones being fractured. Where appropriate, conduct distal perfusion checks by feeling for radial or pedal pulses, feel for warmth, conduct a capillary refill assessment, and assess if the patient can feel both sides equally. One last physical assessment to complete would be assessing the patient's back. Assuming your patient is spinally immobilized, more team members are required to complete the assessment. Typically useful to complete this when we're at the point of moving the patient. Perform a log roll to look and feel for abnormalities. A patient whose repeated trends are changing will aid the clinician in determining if the patient is deteriorating or improving. Using monitoring equipment can aid in completing a thorough physical assessment. More advanced assessment devices can be useful after a thorough physical examination has been completed. A skilled clinician can use point-of-care ultrasound to aid in diagnosing internal bleeding and a pneumothorax.